She's everywhere.
Yeah.
So we have started going live now.
Okay.
Very good. Uh, Jyotraji, may I have your permission to proceed?
Please go ahead.
Thank you. Thank you. Thank you. Good evening, friends. This is Shrenik from Ahmedabad. I am super fortunate being a patient ambassador and moderator of ICS Indian Cancer Study Delhi branch. And today, today's our sweet 16 episode live webinar, and we are having a commendable cancer specialist, Dr. Abhishek. He has served the community for over 10 years as a hematologist and medical oncologist, and his specialization is in treating blood cancer and bone marrow transplant, and currently is the head of the department in the medical oncology hematology at SCG Cancer Center, Ahmedabad. Dr. Vijay, welcome on board, and thank you so very much for joining us today. And we would like to have enriching conversation and sharing your expertise to the audience. Thank you so much for your valued time. Kindly proceed.
Thank you, Shrenik bhai, for introducing me. And I'm extremely grateful to you and Indian Cancer Society for giving me this opportunity. So let me share my slides. So I hope my slides are visible, right?
Yes.
Okay. So today we are going to discuss blood cancers and bone marrow transplant, an area of oncology or field of cancer, I feel, which is not discussed very frequently in public talks and awareness programs due to, I think, few reasons. First is that blood cancers are not very common. If you take all the cancers, roughly 10% of cancers are blood cancers in most of the country's data. And secondly, almost all the cases, say 99% cases of blood cancers, these patients do not have any identifiable cause or etiology which has caused the blood cancer. So preventive aspect is not very reliable in the field of blood cancer. That is probably the second reason why these cancers are not discussed very frequently in public talks. But I feel still there are lots of misconceptions regarding blood cancer, which needs to be cleared, as it might negatively impact, families' decision-making capacity to take decision for individual patient. So we start the discussion, and before discussing blood cancer, I just wanted to introduce our field, that is the field of hematology. I am a hematologist, and this is relatively a new branch of medicine. Formal training programs in India to develop hematologists started around 25, 30 years back. And as a hematologist, we work in three areas of blood disorders. Of course, first is blood cancers. Other area is other blood disorders other than cancerous conditions like low hemoglobin, low platelets, and other bleeding disorders. And third area is revolutionary treatment modality, that is bone marrow transplant, which has evolved over last few years, and it has made possible to cure many previously incurable disorders. So, starting with the basics, there are three different type of cells which circulates in the blood: red cells, white cells, and platelets. So all these cells are formed inside the bone marrow, inside the bone. So bones are not solid. There is a cavity inside it, and there is a substance called bone marrow, which forms all the blood cells. And according to the type, these cells have different functions. For example, red cells, its function is to carry oxygen and supply it to tissues, so it gives us energy to work. So in patients who have low hemoglobin or anemia, you frequently hear them complaining of fatigue, difficulty in breathing, etc. The second type of blood cells are white blood cells. These are the most complex and heterogeneous group of red cells. White blood cells already have around 5 subtypes circulating in the blood, and all of them, their major function is to give immunity to the body and to make us able to fight against infections from the outside. But also at the same time, these cells have a second function which generally nobody is aware of, is to fight against cancer. On daily basis, cancer cells are formed inside us, even in the normal individuals. And these white blood cells, they are in millions of number, and they just keep patrolling our body. And whenever they see a cancer cell, it tries to eliminate it. So that's the second function. One is immunity, and second is to clear off cancer cells. And third type of blood cells are platelets, the tiny cells which you can see at the bottom. These cells are responsible for the blood clotting. So wherever there is injury or any type of bleeding, this cells helps us in controlling the bleeding. So blood cancer is not a single disease, right? So there are many different types of blood cancers, but we can divide it into three major subtypes. One is leukemia, where the actual meaning, or the word leukemia means white blood, and that terminology is derived from the fact that patients with leukemia they have cancer of white blood cells. And if you take the patient's blood sample, in most of the patients, that blood sample will tell you that patient has cancer, because these cancer cells are circulating in the blood. And by just drawing the blood and looking under the microscope, you will be able to find that this patient has leukemia. Second type of blood cancer is lymphoma. Lymphoma is again a type of white blood cell cancer, because lymphocytes is a type of white cell, and cancer of lymphocyte, it is known as a lymphoma. This patients usually have lumps and bumps. And the third variety of blood cancer is myeloma. This is a little bit different cancer from leukemia and lymphoma, where the cancer cells are plasma cells. It is also a type of blood cell that resides inside the bone marrow in most of the cases, and it has a very specific complication that we will discuss later. So, talking of how common is blood cancer. So initially, I told that roughly 10% of all cancers are blood cancer. But if you look at the top 10 cancers in males and females in India, in males, only one type of blood cancer is there, that is NHL, non-Hodgkin's lymphoma, and it's sitting at the ninth position. And in female top 10 cancer, you don't see any blood cancer here. Okay. So incidence is not as high as compared to other cancers. But if you see the age-wise distribution, in children, up to age of 14 years, the most common cancer is a lymphoid leukemia, that is blood cancer. At number 2, number 3, 4, 5, everywhere, it is a variety of a blood cancer. There is a second peak of blood cancers beyond, I feel, around age of 60, 70 years. Again, the risk of blood cancer increases in the form of specific type of leukemias and lymphomas. So this is the first and most commonly asked question from the patient and the relatives, that why our patient has developed a blood cancer, right? And to be honest, in majority of the patient, we don't have any answer, because most of the time it happens just because of bad luck or just by chance. But in few patients, there are identifiable risk factor. This includes chemicals. Patient working when they have occupational exposure to certain agents like benzene in color industry, in radiation, X-ray technicians, or persons dealing with radiation energy, they also have slightly high risk of developing blood cancer in their lifetime. Patients who were treated previously with for some other cancers, if they have received chemotherapy, there is a possibility that later in their life, probably 5, 10 years after the initial exposure of chemotherapy, they probably there are some chances that they can develop blood cancer. Certain infection, patients with HIV or AIDS, they have higher risk of developing certain types of blood cancer. There is a bacteria called H. pylori. which infects the stomach. And sometimes patients with this severe kind of infection can develop blood cancer of stomach, that is lymphoma of stomach. And in few patients, just by treating this bacteria, that cancer can be controlled. And very, very rarely, there is a genetic condition which can lead to cancers in the families. But still, in I would say more than 99% of cases, we can't identify any cause for the development of cancer. So why individual develops cancer? There are so many complicated theories about it, but just in the simple language, patient has developed blood cancer just by chance or just by bad luck. So as earlier I said that immune system not only helps in controlling infections, it also helps in eliminating cancer cells, which are forming on daily basis inside the human body. But sometimes this cancer cell, which are just very tiny in number, they become very smart and they might overrun, oversmart our immune system, or they just escape by some chance. It will form into a full-blown cancer. Uh, Coming to the symptoms, first we'll discuss leukemia. So unfortunately, patients with leukemia, they do not have any specific symptom, which can lead us to think that patient might be having leukemia. If you look at the symptoms, fever, weight loss, difficulty in breathing, weakness, that can happen in any infection as well, right? So we need to be very vigilant. If patient is not responding to routine antibiotics or routine measures of this common symptom, there is a possibility of some serious disorder and underlying serious disorder. So most of the symptoms in patient who develops leukemia are related to low blood counts, because patients with leukemia, it's a cancer of white blood cells. So many of these patients will be having very high white blood cells, and few of them can also have very low white blood cells, because most of the cancer cells are sitting inside the bone marrow. So they might interfere with production of normal red cells, white cells, and platelets. So when patient has low red cells, they will develop difficulty in breathing, fatigue, weakness, etc. When they have low platelets, they will present with bleeding symptoms. And low white blood cells is the most dangerous situation, because they can catch very bad infections from outside. And when your body doesn't help in defending from the organisms, even the best antibiotics cannot work sometimes. Okay. So, fatigue, bleeding symptoms, difficulty in breathing, weakness are the common symptoms, but these patients can also have very high grade fevers, even without the evidence of infections. So leukemia again is not a single disease. There are multiple types, and classification is based first on cell of origin, and which can be divided into myeloid and lymphoid. And secondly is its behavior. Either it's acute or chronic. So acute leukemias, they are very aggressive and they develop very fast. Patient becomes symptomatic within days or weeks of the development of leukemia. Where chronic leukemias, the patient develops symptoms very gradually. And in most of the cases, in chronic myeloid leukemia or in chronic lymphocytic leukemia, patients are diagnosed while doing investigations for some other disorders, or just during routine investigation, we come to know that patient has very high blood count without any symptom. And when you investigate it further, you come to know that patient has probably CML or CLL without any symptoms. So chronic leukemias are indolent, very slow growing, while acute leukemias are very rapid and aggressive. Coming to the lymphoma, lymphoma again can have very similar symptoms related to leukemia. However, lymphoma has a specific sign or symptom, there is enlargement of lymph nodes, because as we discussed previously, lymphoma is a cancer of lymphocytes. Lymphocytes not only circulate in the blood, they are also stationed at certain areas in the body. These are called lymph nodes. It gives you a local immunity. For example, if we have a common cold and fever or throat infection, we feel some enlarged glands inside on our neck. So those are lymph nodes. So in any infection, it can get enlarged. But when patient develops cancer of lymphocytes or lymphoma, this tissue will start enlarging without any reason. So most of this patient comes to us with enlarged lymph nodes, and the common areas are neck, underarms, groins, and abdomen. So lymphoma, again, there are around 40, 50 different types of lymphomas. Mainly, main two divisions are Hodgkin's and non-Hodgkin's. Non-Hodgkin's lymphoma, again, are divided according to type of lymphocytes, so B cells and T cells. And again, like leukemia has acute and chronic division, here you have high grade and low grade lymphoma. Similarly, high grade lymphomas, they come to us with very rapid symptom development. And low-grade lymphomas again can be detected just on routine investigation without patient having any symptoms. The third type of blood cancer is multiple myeloma. So it's a cancer of blood cells known as a plasma cell. So plasma cells, they do not circulate normally in the blood. You need to do the bone marrow to find it out. And these plasma cells have very specific targets. So patients with multiple myeloma have three target organs. First is kidneys. Their kidneys can be they have abnormal kidney function. Their bones are damaged due to the cancer. This is very peculiar finding in multiple myeloma. And third is low hemoglobin. So it also interferes with red cell production. Now, how do we diagnose the blood cancer? So, as we discussed earlier, that most of the blood cells are formed inside the bone marrow. We need to take the sample from the bone itself. So, the safest place to do the bone marrow procedure is hip bone, and between skin and bone, there's just fat, so it's not risky procedure, but it is a painful procedure as your needle penetrates the bone. So this procedure is done under the local anesthesia, but there are no sutures, so it's not a surgery, so it's a daycare procedure. It takes around 10 minutes. So after collecting the bone marrow sample, first it is examined under the microscope. And if you see the diagram on the left, you can see this dark purple color cells. These are cancer cells. So by looking at under the microscope, generally we have the idea that what kind of cancer we are dealing with. And then there are further investigations, special tests to see the how these cells are behaving and what is the characteristic of the cells to exactly subtype the cancer. For example, we need to do a test called flow cytometry to label this as a chronic lymphocytic leukemia. Now, leukemias, your cancer cells are circulating in the blood all over. So staging is not there like other cancer, right? For as lung cancer, it goes to the bone, we call it stage 4 and so on. But in blood cancer, it is already everywhere. So how do we know that how this cancer is going to behave? So in most of the cancers, its behavior or its prognosis is predicted through genetics. As you know that this is not a hereditary disease, but there is some genetic defect which has occurred after the birth or mm, just in the near past before the development of cancer which has caused the cancer. So this genetic defect which we can identify by studying the patient's DNA. And there are two ways. First is karyotype, where patient's chromosomes are studied, and secondly, the DNA itself can be sequenced to look at the specific defects. And by identifying defects, we can have three benefits. One is that it can help in confirming the diagnosis. Secondly, it can tell you the prognosis that how this cancer is going to behave. And thirdly, now we are in the era of targeted therapy. So by finding certain mutation, we can offer a treatment which is targeted specifically against that mutation. So this is the mandatory test which are offered in almost all type of blood cancers. So coming to the treatment, this is a liquid cancer where surgery is not going to help, right? Radiation is also has very limited role. So most of this patient needs to be treated with systemic therapy. That means some form of a drug which can go and in the circulation and which can reach to every corner of the body to clear off cancer cells. So the most conventional treatment is chemotherapy. So this is just an interesting chart which is showing outcome of pediatric blood cancers starting from 1950s. So chemotherapies were invented roughly in 1950s time, and if you see the outcome, it is yeah, and then the gradually different protocols were tested, tried, evolved, improved, and by 1990s you see significant improvement in the patient outcomes. So patients with pediatric patients with ALL, which is lymphoblastic leukemia, they have outcome of around 80%. 80% are the cure rates. 80% children will be cured of ALL if they are treated properly with chemotherapy alone. In AML, numbers are not that great, but still it reached around 40% in 1990s. So in chemotherapy, with chemotherapy, there were two problems. One is that not all patients were getting cured. And secondly, patients who have relapsed disease or patients where cancer comes back after the initial treatment, chemotherapy doesn't do very well. So after 1980s and 90s, the period started where targeted and immunotherapy research became very aggressive to increase the chances of cure rates. And so leukemias and all the blood cancers, it's not chemotherapy now. There are multiple agents. So for leukemias, still chemotherapy has very significant role. But in most of the protocols, we are adding targeted therapies. And so what are the targeted agents? The targeted agents are developed in a way that it tries to find out some targets on the cancer cell. And most of these targeted agents, they do not have any chemotherapy, just proteins or antibodies developed by some laboratory procedures, and these are given to the patient. So they do not have any conventional side effects like chemotherapy, like hair loss or ulcers, diarrhea. Most of the side effects are manageable. And immunotherapies are also becoming very popular now. So immunotherapy, again, it's not is a very broad term. In any treatment which works through immunity, as we discussed, that immune system always helps in fighting the cancer. So by using immunotherapy, we are boosting our own immune system to fight against the cancer. So a number of new immunotherapies are coming to treat blood cancer as well. When we talk about chronic leukemias, right? So there is no chemotherapy, not even injections. Patients with chronic myeloid leukemia, chronic lymphocytic leukemia, once they are diagnosed, most of them are put on oral tablets, just like blood pressure and diabetes, and they do really well. But still, if we take all the blood cancer patients together, I don't think more than 60 or 65% patients are getting cured. Still, there is a huge number of patients where we are not able to give them proper treatment, even with the availability of modern agents, and they fail treatment. So, bone marrow transplant is the is the modality where whenever there is a very high risk disease or patients has relapsed disease, it is the probably this is the only treatment which has a capacity to still cure the disease. So we new treatment. The first idea, I think it emerged almost around 7 decades back, around the time of World War, when patients of atomic bomb survivors were studied. They noticed that patients who survived, they had very low blood counts, and by further investigating it, they found out that their bone marrows were severely damaged due to radiation. And around the same time, second observation was also noticed in patients who survived atomic accidents like Chernobyl, etc. Few of these patients were salvaged by giving bone marrow from healthy donors, mostly their relatives. Few of them patients, not all. So combining these two ideas, some brilliant minds of that time thought that if we kill the bone marrow with limited dose of radiation, not like atomic bombs, probably we can kill patients' blood cancer. And at the same time, we are wiping out normal blood cells also. So if we take bone marrow from healthy individual and transfuse it to the patient, probably we can cure blood cancer. This was the idea of 50s and 60s. Then trials started. Initial 20, 30 years were not very encouraging. Most of the trials failed, but they kept going on. And science evolved gradually, and now we have the established treatment to treat number of hematological malignancies. So at present, there are number of conditions which can be treated with bone marrow transplant, not only cancers, non-cancer condition as well. So cancers or leukemia, mainly when they come back, we offer transplant, or also patients who are having high-risk features at the time of diagnosis, transplant is offered. Lymphoma, most of the time, this transplant is offered when a disease comes back. And in multiple myeloma also, few patients require transplant. Non-cancer conditions like thalassemia. Thalassemia is very common in India, and I think up until now, thalassemia was the number one indication of doing transplant in India. Aplastic anemia is another condition which is not cancer but almost as dangerous as cancer, where bone marrow fails to produce blood cells due to some unknown reason, when you need to replace bone marrow with a normal bone marrow from the donor. And many patients or children mainly, they have hereditary immunological defects which can be corrected with bone marrow transplants. So transplants are of many different types. So first is autologous transplant, that where patients' own stem cells or bone marrow cells are collected, and after giving intense chemo, it's given back. So this type of transplant is mainly used to treat lymphoma and myelomas. But the more complex transplant is called allogenic transplant, where you try to infuse cells from the healthy donors. And according to donor type, also this transplant is divided into different subtypes. So most of the time, it is not as simple as blood group matching, because there is a special system called HLS system which needs to match between donor and patient, and highest possibility of getting a match is in family and mostly siblings. So with any sibling, there is around 25% chance that you will have a full match bone marrow. And if sibling is not matched, the next possibility is parents or children who are always 50% match. So in case we don't have full match donor, we generally go with half match donors. So the first question, whenever patient is undergoing transplant, we hear from the families is that whether is it safe for the donor, right? Because donor has to donate the bone marrow. So answer to this is, for most of the transplant, we don't have to take actual bone marrow. We never puncture donor's bone marrow. And there are special injections when it is given to the donor, donor's blood cells, bone marrow cells, or stem cells. They start circulating inside the blood, and just by taking blood from the peripheral veins and running under one machine, the stem cells can be separated, and rest of the product is given back to the donor. So it is considered very safe for the donor, and donor needs only 1 or 2 days of admission. So this is outline of transplant, how the procedure is done. So everything is defined as a day. So day 0 is when patient is given the stem cells. So week before that, you can see the number in minus 1, 2, 3, 4, 5, 6, 7. This is called the conditioning regimen days, where patient is given chemotherapy plus or minus radiation to kill patient's cancer, and also to clear patient's own bone marrow, because otherwise donor bone marrow cannot be transplanted. So this procedure takes around 7 days, and once it is over, stem cells are infused. So from day 0 to day 14 is the time where patients will not be having any blood cells. It's almost zero. So patient needs transfusions from outside. And the most dangerous situation is low white blood cells, because patients are at very high risk of getting infections from outside. So patients are kept inside the special units called bone marrow transplant units, where even air is purified, and it will restrict the pathogen or bacterial exposures, fungal exposures mainly. By roughly day 14 to 20, the new blood cells from the donor will start forming. And by 28 or 30 days, patient will be having almost normal blood counts, and most of the patient will be free of infection. But these first 30 days are considered the most dangerous time of transplant, where roughly 10% of patient will face some life-threatening event, mostly in the form of infection. So once patient is free of infection, has normal blood counts, we generally discharge them. But for at least 3 to 6 months, there is still risk of getting other complications and infections. So they need to be in very regular touch with us. They come to us every 2 to 3 times per week. And gradually the follow-up frequency increases, medicines list goes down, but around 30-40% patient will have some form of chronic illness which needs continuous attention. And still, there is a small possibility of the original disease coming back even after doing transplant. So patient needs to be surveyed very vigilantly, at least for first 2 years, and then till for a total of at least 5 to 7 years. So I think we are done with the transplant part as well, and probably we can open the session for question answers. So thank you very much.
Thank you, Dr. Abhishek, for explaining everything, in a very simple and clear concept, where, I mean, we are the people, we are not, qualified as a medical professional, but the way in which you explain everything, one can easily understand. Now, before we get into Q&A, I would like to welcome Dr. Priyanka. She's from AIDS. Uh, one, one second. Priyanka change from names, months, and plastic surgery department. Warm welcome, Dr. Priyanka, and also it's really a matter of pleasure that today we have Mrs. Kanchan Banerjee and Mr. Kishore Rao from ICS Bangalore. Thank you so very much for your graceful presence. Thank you once again. Uh, now, sir, I have one important question. What is the overall survival rate after PMT? I mean, irrespective of any category of blood cancer. So, what is overall survival rate of patient after PMT?
Right. So this question we get from each and everyone, but the answer is of course not very simple, right? So as I showed in the slides that transplant there are so many variables. First is disease itself. If you even if you take one disease like acute myeloid leukemia, right? So this leukemia itself will be in different condition before going for transplant. For one patient, it will be high risk leukemia. For second patient, it will be medium intermediate risk leukemia in remission. So there are so many variables starting from the disease itself. Secondly, the patient's age, patient's general condition, patient's organ function, and thirdly development of complications. Okay, so there are few numbers which I can tell you. So there are two type of transplant. One is autologous, second is allogenic. Autologous transplants where patients own stem cells are used. So these transplants are considered very less risky in terms of transplant related complications. Okay, so first thing we are worried about is the procedure itself. Okay, so the risk benefit ratio has to be balanced. So in autologous transplant, risk of dying or risk of mortality is less than 1%. Okay. So once patient come to us for transplant, 99% of them will go home with a successful procedure. But successful procedure doesn't mean that we are curing disease for sure. Okay. For lymphoma, for example, if we are doing transplant for relapsed Hodgkin's lymphoma, the long-term control rates are around 50%. So even your 99% patients are going home. At the end of 5 years, 50% patient will be having their disease coming back. This is for Hodgkin's lymphoma. For thalassemias, where they don't have cancer, so we adjust the transplant that way. There is a healthy donor giving the stem cells. So if patient's age is less, around 5 6 years, patient is healthy, its liver is normal, heart is normal, and has received limited amount of blood transfusion, the cure rates are going up to 90% as well. So the indications are at least around 10 to 15 to do transplant. Donor types are around 3 to 4. So you can just do the mix match. And so there will be a huge amount of numbers. And as I told you, 1% risk is for autologous transplant. In allogenic transplant, the risk is around 10 to 20%, which is related to procedure itself. So it's difficult to put the number, but if you give me one patient, this condition, the type of transplant and the underlying disease, then we will be able to tell you the rough percentages for an individual patient.
Thank you. Before
सर
we
एक
proceed,
सर वन
once
मिनट
again, yeah,
व्हाट मीन्स और ALL एंड और AML आई फॉरगेट इट कि भाई मुझे याद ही नहीं आ रहा कि आपने इसका क्या बताया ALL एंड AML
AML, yeah, AML is acute myeloid leukemia, ALL is acute lymphoid leukemia. So ये जो acute leukemias होते हैं जो aggressive वाले तेजी से बढ़ने वाले उसके दो main types है AML.
ओके
Yeah.
थैंक यू सर थैंक यू सो मच
Doctor, before we proceed to Q&A from the attendees, one more question. What is the overall percentage of this blood cancer between pediatric and the adult community?
So in pediatric, so overall, if you look at the number of cancers in pediatric group, most of the cancers are blood cancers. As I showed you in the slide, around I think 60-70% cancers are blood cancers in pediatric age group. And again, in adults in general, if you in the Indian data, blood cancers are only around 10% of total in adults. But if you look at the top 10 cancers, it is not there in male and female, because in India, mostly in males, we have like oral cancers due to tobacco use and all, and in females, we have breast and stomach cancer. So they are considered rare compared to other cancers. Yeah, but in pediatric, it is a huge percentage.
Thank you. Vijay, if there are any question from audience.
May I ask, Vishali?
Sure, ma'am. Please go
Uh,
ahead, Aruna, ma'am.
Doctor, you said genetic reasons and versus environmental reasons. Obviously, in childhood cancers, there won't be environmental conditions because it happens at such a young age. So, is it mainly the genetic? Or there are, I want to know, they all say there you can't really define any risk factors for childhood cancers,
Yeah.
but what are the main, if one can point out, other than the genetic reason, any other
So, ma'am,
syndromes arise?
yes, correct. So, certain syndromes like Down syndrome, like they have high risk of developing blood cancers very early in the life, and there are some other genetic defects as well, congenital bone marrow defects and certain mutations like NF1 and etc., where there is an increased risk of developing blood cancer. But this subset is very small, probably less than 1% of patients they have some genetic disposition. Most of this patient develop, you correctly says it could not be environmental, right? Because they are very small. How can they have environmental exposure like
Exposure
to
is not there.
pesticides exposures? But still, there are some theories. Even infants, age below 1 year, can also develop blood cancers. It's called infant leukemias, and there are some theories that certain chemical exposure or even some food habits in mother can lead to that thing, but nothing has been proven yet. Secondly, why more pediatric patients develop, or while more children develop leukemias? One explanation is that's the time when your immune system is developing, right? It's being exposed to new and new pathogens and it's learning and all. So there so many mutations are happening inside the immune system in order to evolve, but there are some negative impact also of evolution. So when these cells are evolving, they sometimes acquire bad mutations. So that is not genetic, that is not environmental. That's just because it's evolving, they developed some defects, and that can lead to leukemia and other blood cancers.
Right.
Uh,
One more I have a question. When in the stem cells, it is often said, I mean, now there with the development in medical science, they start preserving it right at the time of birth from the stem cells.
Yeah,
They
yeah.
can also, I mean, there is some probably stem cell bank or something. So from there also the same patient or even the parents or somebody can take those stem cells. Is that
Yeah.
so?
So, ma'am, when we talk of stem cell therapy in general, stem cell means primitive cells which can give rise to mature cells. It could be anything. It could be blood cells, it could be brain cells, it could be spine cells, anything. So stem cell therapy is still undergoing, very rigorous research right now. And approved indication to do stem cell transplantation or to do stem cell therapy is only there for blood-related disorders, nothing else. Okay, you
Pardon?
might it's approved only to treat blood-related disorders, blood cancers, and other blood disorders. You might have heard stem cells being used to treat, say, knee joint pain. They are infusing some stem cells, or even have a patient with having some spinal cord injuries. This all everything is undergoing research. It's not approved yet. And the thing which you mentioned, the storing of cord blood, right, at the time of birth. So cord blood transplants are also can be done to treat blood cancers. But the problem with cord blood transplant is that I showed you the timeline of transplant where it takes almost 2 to 3 weeks for blood count recovery. If you do cord blood transplant, it's going to take at least 4 to 6 weeks. Okay. So around 6 weeks, patient will not be having blood cells if you treat it with the cord blood, because it's very small in number. It's take a lot of time for formation of new cells. So it's almost impossible to keep patient alive for those days without having any life-threatening infection, specifically in India, because hygiene and oral infection rates are very high. So practically no center in India is doing cord blood transplants at this point in time. Most of the time we are taking adult donors. Secondly, what they promise is by storing cord blood for your baby, in future probably it will help full to cure, number of disease, probably 100, 150 disease list they mention. But everything is under research, and if that thing work, probably you don't need that cord. It can be developed from your mature cells also. And cord, if you want to donate, you can donate it to public bank. There are public banks in India which takes that sample, but they will not charge you any money. They will use it for some other patient. Okay, so that cord blood is not going to help the baby itself, technically.
I asked it because when my grandson was born,
Yeah,
his stem cells were preserved. So that's why
yeah,
I
it has
thought.
become a big commercial thing, but at this point in time, it doesn't have any practical relevance.
Thank you.
Doctor, we have our first ever volunteer in Delhi is Mrs. Usha Ohri, and she went to the Sloan Kettering in New York. She was sent by ICS for a leukemia. She's online now, so I've asked her to join in just to say what was it like 30 years ago compared with what you are doing now. Usha?
Hi.
We can't see you. Usha?
Hello.
Usha ma'am is here.
So Usha, let's hear you.
Anji.
I
Hello.
want you to
I
tell.
had my bone marrow transplant done in 85.
85.
Yeah.
That's
Hello.
my
It
birth
was an
year.
allogeneic bone marrow transplant.
That's my birth year.
Go ahead. Go ahead. Why is it different to what you're seeing today?
Hello.
Can you hear?
Ma'am, I think there is
Hello.
some network issue, Usha ji ke paas.
Huh.
That is why her screening currently freeze.
Okay. Okay. So I just wanted you to know that, we've been seeing leukemia cases since way back when. And Usha has been an inspiration for any number of new patients who come to us. We also had another one of our volunteers who had CML, I think it was, which is, recently, and she was treated in Delhi and she's perfectly all right. So we have these very inspirational people in our office itself, and they are able to counsel others who come not to be afraid of bone marrow transplants, because that's the first thing when anyone says BMT is to say Baba re nahi chahiye. Usha, can you come on now? You're muted.
Yeah, she's muted. Yeah.
Usha, you're muted. Chaliye, not successful. Go ahead, please.
No, she can speak now, I guess. I mean, she has unmuted.
Boliye. I don't think she can hear.
Could be.
Yeah, okay, not to worry. Please carry on, doctor.
Hello.
Bolo.
Hello.
Yeah, go ahead, please.
उषा मैम वी कैन हेयर यू, आप बोलिए हम सुन लेंगे. आप स्टार्ट कीजिए.
मैं बोलूं?
Hello.
Hello.
Yeah.
Can you hear me?
Yes, very well. Go ahead.
Hello. Yeah, I had my allogeneic bone marrow transplant done in 1985. I was detected ALL in 1983, but just I was given just 6 months time. Now see, it's 1984, 2024. I'm still alive.
Yeah, yeah.
So,
Great
Hello.
to hear that.
Usha ji,
Hello.
we are celebrating your survivorship together collectively.
Thank you. Thank you.
Yeah. And can you tell us a little bit about Vitu? Gone.
हेलो
Come on. Okay.
हेलो
हाँ बोलो.
आवाज नहीं आ रही
अच्छा कोई
ठीक से
बात.
आवाज नहीं आ रही
वैशाली.
Ma'am, they are there, but maybe we'll speak about it some next time. Better internet connection के साथ, I guess.
हाँ, sure. We'll
So,
try another time. Okay.
ओके
sure, ma'am.
Thank you very much,
ओके
Vishal. Thank you.
ओके
Yeah, please go on, Shrenik bhai, because I think, I will be listening rather than speaking now.
So, I think Anubha has some question. If she want, Anubha, आपको कुछ पूछना
Yes,
तो you can please go
thank you.
ahead.
Thank you, Vishali. Thank you, sir, for simplifying all the difficult terms to us. It was a wonderful session. I have two questions. One is why, in the cases of relapse, we always prefer bone marrow transplant. Why cannot we go with the therapy that has been done, like in cases of if there is a relapse happening after a long break, like 4 or 5 years after. So why don't we go for another chemotherapy? And the second question is, what timeline we consider as relaxing for the blood cancer patients? Like after the after being in remission for 5 years, will there be a lesser chance for a relapse, or will it be a 10 years, or will it be a never?
Right. So answering to your first question, is it specifically for leukemia or lymphoma, anything like that?
Leukemia, because I
Leukemia.
had leukemia, so
Okay. Okay. So, see, leukemia, as you mentioned correctly, if it comes back after a long time, probably after 2 years, there is a possibility that your second round of chemotherapy can still cure it. But as your number of cycles goes on, cure rate generally goes down. So for late relapsers, the scientific data is not very much. Okay, in early relapse, right? So theoretically, most of these leukemias have become refractory to chemo. That's why it has relapsed. First thing. Secondly, when you do transplant, so transplant is it's not just giving chemotherapy and giving cells back. So transplant works in two ways. Well, first is chemotherapy or radiation, which you give before infusing the donor cells. Okay. And secondly, when you infuse the donor stem cells, it's not just stem cells. It contains lymphocytes, also B cells, T cells, etc. from the donor. And these are the
okay.
cells of immune system. So again, they are also going to fight against patient's cancer, and it's a properly defined mechanism. It's called graft versus leukemia effect. So your graft also contains weapons to fight against the leukemia. So chemotherapy or radiation plus GBL. So you are trying to cure the leukemia by in two modes. So in long run, in relapsed leukemias, just treating with chemotherapy almost always it comes back. So risk of relapse is almost universal if you treat the relapsed leukemia just with chemotherapy. Okay.
Okay.
And your second question, yes. So, these numbers, 5 years, 2 years, this everything usually comes through the studies. That's how they are, that's how they are designed. So first 2 years usually considered as the most risky period for the development of relapse, because if some cells have survived from the chemotherapy, probably they are going to come back within 2 years. If they do not come within 2 years, generally they are taken care of by our own immune system. That's the general understanding. If something comes back after that, probably it's a new clone. Okay, it might have emerged from the primary cancer, but it's a new thing which is usually not responding to the your previous chemo. So that also happens usually for next 3 to 4 years. So by 5 years, like other cancer, we generally declare cure, and after
Okay.
that, still the risk of developing cancer might be still little bit higher compared to the normal population, but it is extremely low. So once you cross 5 years, generally we can consider this it as a cure.
Okay.
Yeah.
Thank you so much.
Question if any further questions.
No, sir, there are no more questions. I think we are good.
By the way, once again, I welcome uh, Dr. Priyanka and executives from ICS Bangalore. Thank you very much for joining. And Dr. Abhishek sir, thank you so very much. I mean, for your valued time and explaining everything in a very precise and simple manner, which which any layman can understand without much difficulty. And I guess, by the way, one more point I would like to add here, I mean, particularly for the audience, that we at ICS Delhi, we are conducting such kind of live webinars and uh, inviting the competent and expert cancer specialist like Dr. Abhishek for simple reason that we do not want you to simply web browsers, and we do not want you to follow web browsers if you are not medical professional. Life is very precious. Don't gamble, don't play shot in dark, because if you are playing shot in dark, you are you are going to be victim of your life, and you cannot hold anybody responsible. Not even the web browsers can going to help you in any point of time in case of emergency. So we are bringing the specialists simply for their knowledge sharing and expertise sharing and experience. And remember one thing, that the instructors, they have too many commitments, too many priorities, but simply because of equitancy, simply because of ISIS, Delhi and our coordination, they are giving us that valued time. So, Dr. Abhishek, thank you so very much for your most insightful and enriching conversation and answering all questions. And thank you so very much once again. And
Thank you very much, Neil.
we look forward to having you once again in a future time. Thank you.
Sure, sure. It was great meeting you all. Thank you very much.
Thank
Thanks.
you. You. Bye bye. Bye, everybody. Thank you, everyone. Bye. Thank you for joining us.